Hello and welcome to Gastro Vision. Today we are diving into the part second of latest guidelines on hepatitis B management. So here is the roadmap. First, we will discuss what to do when patients don't respond fully to antivirals. Then we will move on to stopping therapy, the role of interferons, cancer surveillance, and finally pregnancy, HIV, and pediatrics. So let's start with non-response. Step 1. Always check adherence. Many times the problem isn't the drug, it is the dosing. If the patient is taking treatment properly, then we can move on and test for resistant virus variants. So the rule number 1 is adherence before resistance. Now, what are the treatment adjustments? How do we act? If the patient is on nucleoside analogs, then you need to switch to tenofovir. And if the patient is on adifovir, you need to switch to entecavir or tenofovir. If the patient is already on tenofovir, you can consider adding or switching to entecavir. It is simple, it is structured, and it's based on solid evidence. Now, here is a common dilemma. That is low-level HBV DNA, less than 2000 international units per ml, or occasional blips. Good news, don't rush to change therapy. If there is no fibrosis and no resistance, just relax. Think about simpler reasons. Maybe the patient misses doses, or maybe absorption is poor. Don't panic, just investigate. In cirrhosis, the goal is crystal clear, that is undetectable HBV DNA by 12 months. Why so strict? Because these patients are fragile. If the virus is still detectable after a year, time to rethink the strategy. What are the principles of stopping therapy? Stopping antivirals is not a casual decision. It must be done only with an experienced specialist and tight monitoring. We weigh HbSAg, HbEAg, fibrosis, comorbidities, and of course what the patient wants. HbSAg loss is the green light. The safest moment to stop is after HbSAg loss. If anti-HbS develops, that's even better. But without this, the risk is much higher. Now, if you are not ready for HbSAg loss yet, then measure quantitative HbSAg. Low levels tell us the patient may be a good candidate for stopping. High levels may suggest that it may not be a right time for stopping the therapy. For HbEAg positive patients, stopping is possible 12 months after seroconversion and undetectable HBV DNA. But remember, relapse risk is higher. Some experts prefer waiting until HbSAg loss. So be cautious here. In selected HbEAg negative patients, there is another path. If HBV DNA have been undetectable for 3 to 4 years, HbSAg is low and monitoring is possible, therapy may be stopped. But this needs careful selection and ideally in expert centers. Now, you want more precision. Then add HbCrAg and HBV RNA into the mix. They help fine-tune patient selection. The science is still growing, but there are promising tools. What about pegylated interferon? When to use? It is not for every patient, but in the right person, it is very powerful. We check predictive factors, consider side effects, and respect patient choice. Dose is 180 micrograms weekly for 48 weeks. This is the classic regimen. Now, what are the stopping rules for pegylated interferon? Here is a pro tip. At weeks 12 and 24, check HBV DNA and HbSAg. If the numbers don't look good, stop. No point continuing something that wouldn't work. Now, what about combination therapy? Can we give pegylated interferon with nucleoside or nucleotide analog? Not generally, but in special HbEAg negative patients already on nucleotide analogs or nucleoside analogs with low HbSAg, adding pegylated interferon is an option. Think of it as a booster reserved for selected cases. But you need to consider safety first while you give pegylated interferon. Do regular blood checks. Look at blood counts, liver tests, thyroid, even mood changes. Side effects are real. Catch them early. Next is surveillance for liver cancer. All at-risk patients must be enrolled. The gold standard is ultrasound every 6 months by an expert operator. And yes, surveillance continues even if antivirals are working or HbSAg is lost. No shortcuts here. Now, if ultrasound is not clear, use CT or MRI. Biomarkers like AFP can be added, but they are not strong enough alone. We need better biomarkers and research is going. Now, coming to acute hepatitis B in adults, usually no drugs are needed. Most patients clear it naturally. But if there is a compromise in liver function, that's different. Start antivirals immediately and involve a liver transplant team. That is urgent care. Now, what are the therapy rules in pregnancy? In pregnancy, the start drug is tenofovir. Continue it if the patient is already on it. Switch from entecavir or adifovir to tenofovir. And remember, pegylated interferon is no-go in pregnancy. For new starts, treat if HBV DNA is above 2 lakh international units per ml or if HBeAg positive when DNA testing is not available. And the timing matters. Start prophylaxis ideally before the last trimester. Postpartum, you can continue tenofovir if needed. And yes, breastfeeding is safe on tenofovir, a huge relief for mothers. In decompensated cirrhosis or acute on chronic liver failure, stick with entecavir or tenofovir. Never use interferon. It is too risky. Patients with HCC, they still need antivirals regardless of HBV DNA. After curative HCC treatment, tenofovir is the preferred choice. In HIV and HBV co-infection, always treat HBV regardless of ALT or DNA. The antiretroviral regimen should include tenofovir and one golden rule: never stop anti-HBV therapy in these patients. The rebound can be dangerous. Bulevirtide is a newer option. In selected patients with decompensated disease, it can be used alone. And if decompensation happens during therapy, you don't necessarily stop. You can continue, but decisions must be individualized. For HBV and HCV co-infection, here is the deal. Treat HCV with direct antiviral agents. If the patient has cirrhosis, give nucleoside analog therapy during treatment, even if HBV DNA is undetectable. For others, prophylactic NA can be considered to prevent reactivation. Good news for pediatric patients now. In children and adolescent group, multiple drugs are approved. Interferon from year 1, pegylated interferon, lamivudine, entecavir from 2 to 3 years, TAF from 12 years or earlier if the child weighs more than 35 kgs. Plenty of options for young patients. That's all for today. See you in the next video. Thank you.